Welcome back, everyone, to another Friday VMR session. And we have a special treat. Maddie, do you want to mute yourself and say a few words?
Hello, everyone. I'm so excited to present a case today. And I was just saying before the session started, I've been on a stretch of night admitting shifts, and this is from that experience, a memorable case I had. So I'm really excited to share it with you both. How are you doing, Prof. Rez?
I'm doing really well. Who is scribing today?
Hi everyone. My name is Eugene. I'm scribing today.
Eugene, how are you? Are you in your office or home?
No, I'm at home office.
That looks good, man. You doing well? Who's teaching today?
Hi, everyone. It's Zakaria G. I'm excited for the case.
Awesome, Zachary. How are you?
Well, how are you doing?
Doing well. Why don't we get this show on the road? Why don't we switch over to the whiteboard and get Robbie to share some math with us?
All right, well, I guess I will jump in then. So as I said, yeah, this was a case that I saw, I think it was my first admitting shift, and it was very memorable. So here it goes. So this is a 47-year-old man, and his presenting concern was left leg swelling. And I thought that today I would actually kind of start off by just showing a picture of it before giving more HPI. So let me go ahead and share my screen. And all right. Let me know if you can see this. Should be a photo of the legs. So before I give information, 47-year-old left leg pain and swelling, and that was his presenting concern.
Yeah, this takes me back, Professor, to the case that Eugene presented. The picture looks very similar. The angle is different. So I find it very fitting that Eugene is here. And yeah, I'll just describe what I see, and maybe I can pass the mic to Prof. Rez to analyze it. And I see that I have two kind of big picture observations. The first is that I think the left leg is much more swollen than the right leg in terms of its size. And I don't think there's focality to that swelling. So I think sometimes I've seen patients who have a monoarticular arthritis of their knee, and so there's some swelling that is deceptive to be diffuse, but actually it's all centered around the knee, and I don't see that to be the case here. It also seems to extend pretty proximally, so I feel like the left thigh is bigger than the right thigh. The other observation I wanted to share here is often noise, but that there is abrupt loss of hair at the mid-calf. And there seems to be a similar loss of hair in the thighs. And so I think we're classically taught that that's a sign that there might be a neurologic or vascular issue uh, feeding the hair, but I think oftentimes that's not the case, and the result of socks or whatnot. So I'm just noticing, I will be honest with you, is just hair loss in the pattern of contact, often with shorts, pants, or socks. So those are my two observations, but I'm curious what Prof. Rez is making of them, or if he has anything else that he's seeing.
Yeah, that's awesome that you it made you think of Eugene's case. I mean, we've talked about this many times on VMR. The way that the circulation is that the left iliac vein goes under the right iliac artery. And if someone can just put a Google image in the chat so you can actually visualize this. So all causes of swelling are more pronounced on the left than the right. But anytime you notice a difference, despite knowing the anatomy, you should frame it in your mind as asymmetric swelling until proven otherwise. And we saw in Eugene's case that it ended up being nephrotic syndrome, and the left side was just, or the right side, one of the sides was a little more intense. And I think the best approach to swelling of the lower extremities, once you identify it as unilateral, is one, getting a time course, and then two, just picturing the anatomy and like what exists there. Probably if you're applying base rate of disease, a clot or cellulitis are the most common causes of unilateral lower extremity swelling. Here, there's no evidence of infection on the skin. So it seems like whatever is driving this is deeper. And the question becomes, is it because of pathology at the muscle, at the bone, at the fascia, at the vein. And I think I'll leave it at that until we get more data so we can refine the problem to make better progress.
All right, amazing. So to give you some more information about the history, so in terms of the time course, he has noticed this left leg swelling and pain for the past 2 days. He actually said that the pain is more severe in his left groin area, but he's really noticed swelling of the whole leg. He can't recall any trauma, no recent falls. He's just noticed that it kind of progressively got more swollen over the past 2 days. When asked about review of systems, it is revealed that he's noticed a 25-pound unintentional weight loss over the past 2 months. He has not had any fevers or night sweats or chills, no chest pain, shortness of breath, vomiting, diarrhea. When he mentioned that the pain was more severe in his groin area, he has not noticed any swelling or masses in his genital area, no blood in his stool. When asked about kind of changes in bowel movements, he reports that he has recently noticed the urge to defecate at night, but then when he goes to the bathroom, it's just gas. And then he's noticed some increased mucus in his stool, but no blood or change in the consistency of that. He has no known medical history. He does not take any medications. Social history, he works in a restaurant in Denver, washing dishes. He was born in Mexico, but has lived in Denver for 9 years. No real pertinent health-related behaviors. He does not use tobacco or any other drugs. He used to drink about a beer per day, but his last drink was 3 months ago. And no allergies. And then vitals, he was very he was stable. So he was afebrile, his heart rate and blood pressure were normal. He was satting well on room air. And then for physical exam, general appearance, he was a thin man. He was not in any acute distress. You see that like before he removed his pants for this photo, he was wearing baggy pants, and he had this like string that was like holding up his pants, kind of inferring that he had lost quite a lot of weight and now needed to add a string to hold up his pants. His abdominal exam was benign. His heart and lung exam were totally normal. And then the extremities, you can see in that photo, there was pitting edema on that left leg from the foot all the way up until the hip, so including the shin and the thigh. The sensation was intact, the pulses were intact, and because he mentioned pain in the groin area, kind of looking at the groin, there were no palpable masses there. And I'll pause there.
I think this is really interesting, Maddie, and I'll share my preliminary thoughts and then ask Robbie to layer upon those because there's so much signal here. And the question becomes like, where do we focus our attention to? And I'll say this really quickly that when we think of lower extremity swelling, if you want to take your schema to the next level, maybe you say, okay, if I filter that through pain, what causes rise and what causes lessen? For example, in Eugene's patient, the person had nephrotic syndrome. They ended up having, I believe, a lot of pain somewhere. But if it's just fluid, like from heart or kidney disease or cirrhosis, it really shouldn't cause pain. You think of pain when there's actual like ischemia or tension buildup or inflammation. So that's an interesting filter. But really what got my attention on this aliquot was the weight loss, which I'll leave for Robbie to tackle. But more importantly was this sensation of having to defecate without much coming out. You should be able to translate that to a medical term known as tenesmus. And it's a very powerful medical term because even before Maddie shared with us that the patient was like having mucousy stuff come out, tenesmus really prioritizes the possibility of rectal inflammation. I don't know if it's 100% predictive, but it really makes you think about rectal inflammation, which then your mind translates into proctitis. So now all of a sudden, I'm thinking, is the leg just a consequence of what's driving the pathology within the rectum? And the rectum really becomes my point of interest. And but maybe I'll just stop there, and because I think there's more to discuss, like what's the DDX for proctitis, what about the weight loss, and ask Robbie to share his wisdom in that area.
Rafraz, can I ask you for a favor? Can I share my thoughts about weight loss and then come back to you after that? Because I think it'll enlighten the reflections on the rectal pathology you're coming up here, because I know that you've been thinking about it, and we shared some pictures and images about that space. But I think it's actually a good time to talk about the weight loss, because I think it's impossible not to think about the localizing symptom of tenesmus here in the context of the weight loss. And just like Prof. Rez, I think mentioned when talking about lower extremity edema, that we've talked about this quite a bit, and that he updated us by sharing a different vision, a different version of it. I'll do the same for weight loss. And I'll just remind you for a moment, though, that we've talked about weight loss many times as a caloric deficiency and a mathematical equation, being a deficiency of intake or an excess of consumption. And so either your patient's not eating enough or consuming too much. And I think famously Prof. Rez illustrates the calorie going into his mouth and digested, so on and so forth. And I think that's a great anchoring principle to really have a comprehensive, almost anatomical framework for weight loss. If you're viewing it from another lens, which is to try to ask yourself, how often does weight loss attach to a localized phenomenon versus a systemic one? And I think this is a conversation that's worth having in this case, because many of the symptoms we're hearing so far can be localized. And so I'll just take a moment to argue that so far, it can be easy to simplify this case as pelvic crowding. Now, what do I mean by that? I mean by that the rectal symptoms, the groin symptoms of pain, and then the lymphatic or venous hypertension extending to the leg can be, of course, complex, but also plausible is this idea that there's a strategically located process taking up space, causing discomfort in the ipsilateral pelvis, and then causing compression on the rectum and compression on the adjacent lymphatic and venous structures. And so I'm saying that with you because you might find that as an elegant solution, but there's a problem with that hypothesis. And so let me share that problem by going back to the weight loss. There was a really eye-opening study that happened in the New England Journal that changed how I conceptualize weight loss. And it taught me that it is virtually impossible for a localized cancer to cause weight loss. When you look at patients who have had weight loss in the context of malignancy, the vast, vast, vast majority of them have widespread metastatic disease, except people who have upper GI tumors like esophageal, stomach, pancreas, biliary, so on and so forth. So unless your tumor is strategically located to cause maldigestion or malabsorption, it has to be metastatic to consume enough calories to cause weight loss. So if we're positing here that a patient has a localized process in the left side of his pelvis causing this syndrome, there's a disconnect between how much weight he's losing. And the weight loss brings in a whole other sphere that doesn't merge well yet with what we're seeing. And that other sphere is either he has concomitant upper, not lower, GI tract disease, or this disease is actually the tip of the iceberg and it's systemic. So if you're visualizing his body, you can simplify what you're seeing, that there's something in the pelvis, but the weight loss is telling you that that's actually incomplete, that either he has something widespread or he has something in his pelvis and his upper GI tract. And so with that in mind, I'd love to pass the mic to Prof. Rez to see what more we can get out of the rectal pelvic symptoms and see how they merge with the weight loss. Because we may not be able to get more, your instinct maybe to get more information, but I'd be really curious, honestly, what thoughts are flowing through your mind.
I think that's so clever. And really, my approach to proctitis was changed by something you taught me, Robbie. And it's the following. I think certain mnemonics are really helpful, especially if you don't see a problem frequently. So, for example, colitis as an internist, I don't see that often. And there was a mnemonic that Gurpreet Dhaliwal shared with me, and I've never forgotten the top causes of colitis. I'm sharing this with you because the thing that Robbie taught me is like, how does proctitis differ from colitis? And for colitis, it's easy to remember the eyes, infection, inflammatory bowel disease comes in the form of Crohn's and UC, ischemia, and finally, infiltration from malignancy or eosinophils. The question becomes with proctitis, which this patient almost certainly has, is how does our framework change? Well, if we're considering inflammatory bowel disease, it prioritizes UC over Crohn's. Though this patient's age is not really in that bimodal distribution we often associate with inflammatory bowel disease. UC always involves the rectum and tracks proximal. But the rectum, you can also think about like what's being inserted into the rectum. So all of a sudden, foreign body comes into play. If there's any kind of, a sexual activity that introduces a foreign body into the rectum, that can lead to inflammation. If you get really constipated in the rectum, this can decrease blood flow to the rectum because of the rise in pressure. And this is referred to as stair-curl colitis. And along those lines of sexual activity, STIs, all of a sudden they get prioritized when you're thinking of proctitis. And this includes stuff like chlamydia and the various serovars that can be associated with lymphogranuloma venereum. And Robbie, I just mentioned that because of the groin pain, and I wonder if there could be a lymph node that's there that's adjacent to the rectum that's causing proctitis. And then we saw it with CMV, HSV, and it's not as much in the news now, but monkeypox as a cause of rectal inflammation. So, of course, there could be rectal cancer, as we discussed. But I think for this patient, I wouldn't necessarily say because they're from Mexico that I have to prioritize infections that are endemic to that region. No, not at all. I would just treat this like any other individual. And for me, I think what would be most important is getting a sexual history and sending all the STIs and understanding why might the rectum be inflamed. And if I were to do one study in this patient, it wouldn't be a lower extremity ultrasound. It would actually be a CT abdomen pelvis with contrast and making sure I get the venous structures to see if there could be some kind of compression of a more proximal vein leading to the swelling, but also looking at the rectum to get we're right now giving a clinical diagnosis of proctitis, but we want to confirm that with a radiographic finding. And then ultimately, we usually end there, clinical radiographic in terms of inflammation, but really the gold standard is always going to be a biopsy for both colon and rectum to show inflammation. Robbie, anything else to sprinkle on before we move forward? Any other way you're making this link with the weight loss based on the template that you used?
Not a proper, as I'm right there with you. I just have an itch to ask Maddie. I'm really curious just for my own learning in the ER because I might have missed the deep dive review of systems that you'd asked, and it would be such a shame to solve this problem as just a like swelling without the associated features. How willing and able was the patient? Did you have to coax those really powerful clues out of him, or was he ready to volunteer them easily?
Yeah, it wasn't too difficult. I was just I generally ask like when I'm admitting patient just about blood and stool and kind of changes in bowel habits. And no, he was pretty forthcoming. He was like, oh yeah, I've had this weird thing where I like get up to go to the bathroom at night, but then nothing comes out. So it wasn't that hard to get that information.
Yeah, there's a little teaching point in there that I'm actually reflecting on this probably from a personal experience that I missed a really important diagnosis yesterday because I was moving too fast in the emergency room, and I'll share it with you all in the academy soon, I promise. But I was just struck by the value in Eugene and your cases side by side. Eugene told us that the patient came in with left swelling, but he also told us that the patient reported periorbital swelling, and I remember that. And then you're telling us that, the patient has other accompanying features. And it's so easy to move so fast when you're taking care of patients to just focus on the leg swelling. And how powerful, how different is our conversation now, Prof. Rez, from these associated features. And so I just keep reminding myself, and then I remind you to just first slow down, listen, let the patient finish telling their story. Because if you did what I did and you interrupt them and move fast, you might miss key data. And I'm so glad we know of the rectal symptoms, because as you just heard from Prez, it's just a complete game changer for this case.
Dude, we're all dying to know what happened.
I know.
Oh, it's a long story, Prof. Rez. Yeah, you'll hear about it, I promise.
Yeah, I think it does show like the value of the review systems, because I wasn't really anticipating getting a significant answer when asked about that, but I'm glad I asked. All right, so to give you some more, and so Prof. Rez, to answer your question about the sexual history, so he reported he had one female sexual partner in the last 3 months. So for the next aliquot, we'll give you some labs. His CBC, his white count was 5.8. Hemoglobin was 9.9 with an MCV of 83. Platelets were 406. For his iron studies, his ferritin was 125, iron of 21, TIBC of 226, and an iron saturation of 9%. His BNP was completely normal. His creatinine was 0.5. He had some mild hypokalemia to 3.2. His liver enzymes were normal. His LDH was 357. His uric acid was 4.1. Proper as an ultrasound, we did get CT abdomen pelvis, but first an ultrasound was done, and that did not show any DVT visualized. And then the last piece of information I wanted to show you was a chest X-ray. And I can tell you the read, but just wanted to get your initial impressions before I tell you the read. All right.
My reflex impressions are two things. The first is I think that it's so powerful that Alec commented in the chat at the same time, because I learned my reflex observation from him. And it spiraled a series of thoughts. It's amazing what an image can do for you sometimes, but my thoughts are sad. And I'll tell you why. What I'm seeing, Prof. Rez, and I won't, I'll just kind of stick to interpreting the X-ray and then pass the mic to you to integrate it with everything else. So this is such an important X-ray for everybody to learn. What you're seeing are large, well circumscribed, rounded, peripheral nodules. That description of large, well-circumcised, rounded, and peripheral is characteristic of an entity that a CT scan will ultimately confirm, but a hunch of an entity called cannonball disease. And cannonball disease is a subset of nodular disease with the same DDX for widespread nodules that you'll find on our website, but the large nature of them prioritizes cancer. And the truth is, it actually prioritizes a subset of cancers, but you shouldn't extract that, limit yourself to just that smaller DDX, which you can easily look up. It's widely Googleable and ChatGPTable. But unfortunately, you show me this X-ray, and thanks to Alex's outstanding case that he presented on Andrew Sanchez's podcast, Diagnostic Atypia, it really stuck with me. So that's my cannonball imprints prioritizing malignancy. Your thoughts, Prof. Red?
I mean, that's just so beautifully interpreted. Maddie, can I ask, why was a chest X-ray done?
It's a great question. When you're admitting, this chest X-ray was actually already done before I saw the patient.
Yeah.
so the ED obtained it. And it's a great question because he wasn't reporting any respiratory symptoms and he was satting well on room air. So I don't have a great explanation for why it was obtained. I'm happy they did get it,
Yeah.
but I don't know what prompted it.
And here's the good news. Like, I have to say this. I don't think everyone that gets admitted to the hospital has to get a chest X-ray or an EKG or a troponin. And I don't even want to speculate to what the ED doctor was thinking, because there could be a scenario where the patient did describe shortness of breath that wasn't communicated to you for sure. But then I also want to say this, that because we were going to chase the CT abdomen and pelvis, you get the lower lung fields and you would have seen pathology there. And then that would have prompted you to probably get cross-sectional imaging of the lungs. So I was just more curious. I'm glad, like you said, we got it, but I don't want this for the audience that is watching this, just to know, like, you really got to go where the hypothesis is taking you, rather than just, because when you get random tests or you get random exam findings and they're not then you're setting yourself up for diagnostic failure. You absolutely are. Like, I don't know what happened the other day, but like, let's say you get an ESR and C. diff and it's elevated. What do you do with that? Like, you never get an ESR and C. diff. And that happened to me. And it's like, okay, I don't know. Maybe patients with C. diff have elevated ESRs. But if we can go back to the whiteboard, because Robbie did such a good job of interpreting the chest X-ray, I think that the labs really are helpful here, because you've confirmed iron deficiency anemia. And, you know, Robbie, probably for like 8 years, I would have said if your ferritin's above 100, unlikely you're iron deficient. But my views on that have shifted. And I know many people were probably there before I was, because you can use the percent sat here. It's less than 14%. So you have iron deficiency. And then the ferritin now and the weight loss is suggestive of inflammation, but the weight loss also may be secondary to some pathology within the gastrointestinal tract. And so iron deficiency anemia, why? And trust me, that ferritin would be much lower if there wasn't a background of inflammation. The number one place to look for in postmenopausal women and men is the GI tract. Oftentimes, iron deficiency becomes an exercise of understanding where are you losing hemoglobin. Why? Because the majority of iron, about 40% of our iron stores, are incorporated into hemoglobin, because hemoglobin needs iron and it comes from an external source. So that's why whenever someone's iron deficient, the first question is, where is the hemoglobin? There are other causes of iron deficiency, like malabsorption, celiac disease, or CKD, heart failure, where you get increased hepcidin and decreased absorption through the GI tract. So for me, Robbie, now I want cross-sectional image. I don't want to anchor here, but I'm prioritizing a cancer that is involving the rectum, is involving the lungs, and it probably didn't start in the lung, probably started somewhere else, probably the rectum. I have Radiopedia opened up here, and the cancers they say is renal cell, choriocarcinoma, synovial carcinoma, which we had on RLR, prostate cancer. But what would I do next is I would get cross-sectional imaging of the chest, the abdomen, and the pelvis with contrast. And I think that's going to make leaps in terms of diagnostic clarity. Anything else to add, Robbie, before we move forward?
No. Just to clarify, just to update the hypothesis of the weight loss. So I think now you have found that systemic disease, and I think it's yeah, I think the problem representation now is the leg is swollen, the rectum is involved, the groin hurts, and the patient has widespread entity. So I think that you no longer really have to go fishing for why the patient has weight loss. You're not in the isolated upper gastrointestinal tract category. You're now in the systemic weight loss category. So now we can kind of put the weight loss aside. We don't have to think about it. We know we have to, our focus now is understanding this, what is this systemic disease? Awesome. Mike to you, Maddie.
All right. Getting chills from the discussion from both of you. So just to kind of, you nailed the read, but just to say what it said, was numerous nodular opacities through the lungs bilaterally that said could be due to pulmonary metastasis. And also commented on this asymmetric prominent soft tissue density over the right paratracheal stripe that could be due to enlarged mediastinal lymph nodes. So as you wanted, Prof. Rez, the next outlook would be the CT chest, abdomen, pelvis. I also have the imaging for this just because I think the imaging in this case is interesting.
Our radiologist is Robbie, so don't give him the read. He's been
I will
practicing.
give the read. I have two separate images. One is like in the lung field, and then one is in the
Give him both.
abdominal. Okay. So well, let's start with you want the lung first or the abdominal and pelvis first?
You lead, I'll dance with
All
you.
right. Let's start with the lung. Sure.
Yeah, like Alice said, I have to wait for the read from Hawaii, Prof. Rez, and I'm a very impatient human being, as you know all too well. And my bowl of acai discovered. It was gone in 3 seconds. Yeah, I'll just talk out loud and see what you think, Prof. Rez. I think we're seeing confirmation of the cannonball physiology, large peripheral, very well rounded. Maddie, if you wouldn't mind scrolling up one, oh yeah, maybe play it one more time. I'm just looking at the mediastinum again to see what observation was. And mediastinal fullness is very, very difficult for me, honestly. So yeah, I see a collapsed esophagus, trachea. I'm trying to see if there's a lot of mediastinal fullness. And a different window would help you see it much more clearly, the mediastinal window. I don't see a large mediastinal mass, but I wouldn't be surprised if we window it to the mediastinal window that you might see some fullness. And what fullness in the mediastinum is by inference lymphadenopathy. So when you give a CT scan with contrast, you light up everything in the mediastinum except lymph nodes. And so the aorta will be full of contrast, the pulmonary artery will be full of contrast. And if the mediastinum is full and it's not lighting up with contrast, the radiologist deduced by inference that must be lymphadenopathy. And so, yeah, that would be my take. Anything you want to sprinkle in, Prof. Rez? Okay, all right.
All right, let me show you
Belly is the hard one, Prof. Rez.
the belly. Share. Okay.
So we're starting from below.
So sorry, we'll start from the top.
Okay, all right.
All right. Here we go.
So I see a liver cyst, but no mets. Spleen looks normal. There is I can't tell if there's a large hydronephrosis on the left side. They're, I think, increasingly more apparent. Sometimes it's difficult to tell if it's a renal cyst or hydro, so you have to follow it down. And actually, there's bilateral left greater than right hydronephrosis. There's no lesions in the kidney or the liver that I can appreciate. Also looking at the bones at the same time, there's a large amount of stool and with some dilation of the bowel. And this is the bladder coming into view, very anterior structure that's not herniated, Prof. Rez. And then there's a very large left pelvic mass. Yeah, right there. Thank you, Maddie. And then those are the hips bilaterally. There's no hip effusion or hip mets that I can see. And if you scroll all the way down, I'm going to be paying very close attention to the scrotum. Because the testicular cancer is the most common cancer in young to middle-aged adults, and we don't see the testes in good view here. Just so you know, if you look at the iliac bone, I think I saw something on the way up. Yeah, I think that if you compare the left and right iliac bone, so look how generous and happy the right acetabulum is versus the left, and there's erosion into the bone.
Yeah. Anything else you want to add, Prof. Rez?
I mean, that's just such a beautiful read. Is that, Maddie, was that the rectum, or like, can you show us the rectum? The rectum sits behind the bladder, of course. So I always look for the bladder, and I don't know, it seems that that mass, right? Because now we're trying to understand, is that, so can you scroll back a little bit? Because I'm seeing the rectal wall. I think, go back a little more. Okay. Good. So the rectum should be in that area. And now we know why this patient has left lower extremity swelling, because that was a complaint that they came in with, because that mass has to be compressing, I would imagine, the venous system. But yeah, I would love to hear what the radiologist says. Honestly, for me, it's difficult to see the rectum. So I don't know if that's replacing it or if that's within, like, but there's definitely tenesmus. So I'd be curious to what the final read was.
Yeah, well, Robbie, you got it all. So, to start, maybe we'll just start from the top in the chest. So there was right apical pulmonary partially necrotic mass that was 4.5 centimeters, and then innumerable bilateral pulmonary metastases. And then for the abdomen and pelvis, so they described it as an aggressive, large, soft tissue mass in the left hemipelvis, measuring 11.8 centimeters with osseous erosions into the left ischium, acetabulum, and left sacrum, which is what Robbie was pointing out. And then there was displacement of the bladder, prostate, and rectosigmoid colon due to kind of like the mass effect. And then Robbie mentioned the kidneys. So there was left hydrouteronephrosis related to mass effect of obstruction of, in the distal left ureter by the left hemipelvis mass. And then Reza, what you were saying is that there was encasement of the internal iliac vessels and a suspected acute DVT in the left external iliac vein, located immediately anterior and medial to the pelvic mass. Then there was some scattered retroperitoneal, right lower quadrant, and left external iliac lymph nodes. I'll pause there.
Yeah, I think what we get here is, I mean, there's so, first of all, this is wild. Like the mass effect, Maddie, like I've never seen anything like this. And what we're getting here is that even in the lung windows, when they say you have a necrotic mass, what does that mean? It means that that mass is growing so fast that it's outgrowing the blood supply and literally becoming necrotic. So when you see necrotic mass in the lung field, it's because whatever this process is, this pathology is, it's very aggressive. And another example of showing the aggressiveness of this pathology is how it's invading into the bone. Like that's telling you that this likely cancer is so aggressive that this is happening rather very rapidly. And that's why whenever you see a pulmonary mass, it's always helpful to look at a prior chest x-ray to put a timeline on that mass too, because the rate of growth of mass informs the differential diagnosis for the mass in terms of what kind of cancer. And so the necrotic lung mass, the invasion into the bone, it's just, this thing is going at a very rapid rate. To me, I can't think of anything other than a sarcoma that can do all this. Like I just can't. And when it comes to sarcomas, it just, you just follow where the pathology is. So if it's muscle, it'd be a rhabdomyosarcoma. If it's vessel, it would be an angiosarcoma. If it's vessel, muscle, whatever, then you start saying angiomyo, if such a thing exists. So it just happens to do with where that origin is. But at this point, what you really need is a tissue, and you probably need palliative care involved as well, because the prognosis is going to be so poor for this individual. Robbie, what else do you got to add on this case?
No, I'm right there with you, Professor. I'll just share a thought that I had discarded that I've since not quite discarded, but I think whenever you're in the world of a retroperitoneal process, radiologists have a very hard time distinguishing a retroperitoneal mass from a large conglomerate of retroperitoneal lymph nodes. And so I've had cases just like this where the final diagnosis was actually diffuse large B-cell lymphoma, and it wasn't a mass. It looked like a mass, but it was actually a massive collection of lymph nodes. But the clue that that's less likely and that this case is leaning strongly, as Prof. Rez said, to a sarcoma, is the invasion. So you might ask yourself, what is the value of seeing bony destruction here diagnostically? And it's huge. Because, and it brings up a little bit of a subtle point about the difference between compression and invasion. Anything large can compress. So here, if we had just that the iliac vein was compressed and the ureter was compressed, I think a conglomerate of lymph nodes suggesting either metastatic testicular cancer or a lymphoma would be plausible. Of course, you would have to appropriately acknowledge that massive unilateral conglomerates of lymph nodes, that other side is a big counter-argument against that. And that has to be acknowledged. But when the moment that this mass is actually deciding to break through bone, it's not compressing bone, it's actively eating into bone. And a conglomerate of lymph nodes is much less likely to do that. And so I'm right there with you, Prof. Rez. I think my leading diagnosis within the realm of retroperitoneal mass it is divided into primary sarcoma, neurogenic tumors versus metastatic. Metastatic is either solid from local organs, GI, GU, GYN, or lymphadenopathy. Here, the large nature, and not just the compression, but the invasion, I think has me really worried about sarcoma, which, of course, is on, unfortunately, the list of cannonball, the short list of cannonball mats. And I think, Prof. Rez, one thing that I actually don't know, would love I don't spend enough time in the hospital to see how this plays out, honestly, is do patients like this get a nephrostomy tube further? I'm curious what your experience is for management-wise. Would you be calling urology or IR for nephrostomy, or does the fact that his creatinine is, shoot, I missed that. His creatinine is 5.5. I completely missed that.
Oh,
Yeah,
no. The creatinine is 0.5.
0.5. Yeah, I thought so. That's what I thought. Yeah, so I'm curious just to learn from you, Prof. Rez, what happens to the ureter in the situation with the normal creatinine?
Yeah, it's a really good question. And this goes back to like when they tell you in medical school, if you remove one kidney, your kidney function shouldn't be affected because it's a redundant system. That's actually not true. Like you're losing nephrons and you are going to have a bump in your creatinine. As far as like the management here, honestly, I'm less worried about that kidney right now, Robbie. I'm more worried about personally. I don't know what the right answer is, whether you place a nephrostomy tube or not. I wouldn't even go down that route because right now what worries me is just the bigger picture of this guy likely having weeks to months, I think, of survival. And so as a hospitalist, I wouldn't rush to involve nephrology and get too many cooks in the kitchen. It would just be like, let me get a biopsy, confirm the hunch, and then simultaneously get palliative care on board and oncology to help navigate what the patient's prognosis is and what to expect. And then less becomes more in this context.
Yeah, and Robbie, actually, just to answer your question, so before more data, I can talk like a little bit about management. So at this point, because of the DVT, he was started on a heparin drip. Oncology had recommended starting allopurinol for tumor lysis syndrome prophylaxis, and those TLS labs were monitored. And then in terms of your question about the kidney, so over the subsequent days, he actually had worsening renal function with his creatinine up to 1.2. And urology initially got involved, and they said that in these large pelvic mass cases, ureteral stents have a high possibility of becoming obstructed. So they actually recommended a percutaneous tube. So IR did eventually place, he got a left nephrostomy tube for that. But in terms of some additional workup, so from the beginning, tumor markers were sent. An HCG tumor marker was negative. And AFP tumor marker was significantly elevated at 10,000, that on repeat a few days later rose to 18,000. He got an ultrasound of his scrotum and testicles that was normal. And then he ultimately got a CT-guided biopsy of the lung mass. And maybe I'll pause there.
I forget, Prof. Rez, I completely lost track.
I'll just comment a little bit on the nephrostomy tube and then leave the AFP for you to discuss. But, you know, what I'm I would say probably over the last couple years, as I'm almost a decade out of residency, I'm much more selective in who I involve. Why? You know, Robbie asked the question as a hospitalist. Because if I involve an orthopedic doctor, their focus appropriately is the joint. And like if I involve a urologist, their focus appropriately is just the kidney. You see, as an internist, you can view the whole picture. So you know, I can't involve someone, they give a recommendation, and then me say I disagree with them, and I'm not gonna like that's just not my style, and I think it looks bad for hospital-based care. So it's about being selective and like prioritizing what matters most and where you think the case is heading. So in a situation like this, um, yeah, I think I would just prioritize getting tissue more so than anything, and then involving palliative care and oncology. The rest of the stuff, I think the focus then really becomes, quality and palliative. But yeah, so I think that's just important, and that's like a nuance where every abnormality you see doesn't necessarily mean you have to involve this person or that person. And once you involve them, then you're almost constrained to their recommendations, which you may not ultimately agree with. Now, this is an evolution as you go through your training and develop experience, because earlier me would be so nervous and anxious and not want to miss anything to involve so many people. But then that can be a disaster when you involve the person, not because they're not doing their job right, but they're not seeing a whole picture like an internist does.
Rafrez, I would pay money to sit in a room and watch you talk to my most trusted colleague, Mike Najad, who I think 9 times out of 10 says good medicine is all about protecting the patient from us. And he literally is, and of course, this comment without context may be misinterpreted, but I think it layers on very well to what Prof. Rez just says, which of course is not a comment on this case. There's a lot of nuances here that we're not privy to, but as a general thing about the internist being in the great position to think forward for the patient and really yeah, to really make sure that we don't over medicalize things. I think there's a really other important learning point to be made here. I think there's 2 learning points that Prof. Rez and I can dance and touch on. The first is what site was biopsied, and the second is the value of tumor markers. And so the site biopsied here is crucial. So whenever you're biopsying a site, the first variable that influences everything you do is accessibility. And if a proceduralist tells you that you cannot access a site, then it's off the table. So there's no point pontificating about it. So even though a brain mass might be very, very juicy for biopsy, its accessibility will always make it be at the bottom of the list no matter what else. So accessibility drives a lot. But after you eliminate the factor of accessibility, the decision to biopsy something is influenced by what you think would help you in parallel get 2 things, a diagnosis and staging. So if you can accomplish diagnostic clarity and staging simultaneously, you've done the patient a great service. So let's play this exercise. Prof. Rez made the argument that he thinks that this is a mass originating in the pelvis that has spread to the lungs. So if we do the exercise of biopsying the pelvis, we may accomplish great diagnostic clarity, but we don't accomplish staging. So this is why the team appropriately went to biopsy the lung metastases, because they felt it was accessible. Lung lesions are often accessible either percutaneously if they're distal or endobronchially if they're central. And in this case, if the patient had if we thought that the patient had a primary lung cancer with spread into the abdomen, we probably would have gone the exact opposite direction and biopsied the abdominal lesion. But here, since the pattern of spread appears to be consistent with spread into the lungs, approaching the lungs was key and will likely give us staging and clarity, unless, of course, this is an unusual case. And we've had many unusual cases on the VMR. But that's, I think, the rationale. In terms of tumor markers, so Prof. Rez, maybe I could pass the mic to you. I've talked so much. Just your general spiel on tumor markers and.
Yeah, first of all, I just wanted to say, like, Mike Najad is just a legend. Like, how do you capture all that complexity in just like one sentence? And I'm going to capture it with tumor markers. Is it tumor markers or too many markers? let that sit with all of you, because yeah, like there's a context to do that. The tumor markers, especially for prognosticating or seeing response to treatment. But as far as specificity, tumor markers end up being too many markers, where we actually had a patient with, we always come back to the DC, Robbie, where that patient had like a huge ovarian mass, very high tumor markers, and was tuberculosis. So this is my whole point of like when you send tests, and like I actually don't know how to interpret this very high AFP. I would give it the respect it deserves, and I would put it into GPT. But we already ultrasounded the testes. Like we know that there isn't like a cancer there. Germ cell tumors can release AFP, but that would be just such an odd location, I think. So I'm not sure what to do with that, and I don't. It doesn't do anything but tell me like what is that biopsy, because I think I'm still heavy on the sarcoma hypothesis, unless I learn something through research that when the AFP is above this threshold, it must be this. The other thing I wanted to say, and I'd love to know if Robbie knows if that AFP does narrow the DDX, but remember this patient came in with leg swelling, and we understood why, but we also said this patient had rectal inflammation. And this just comes back to like, I always forget, Robbie, like if there's adjacent pathology, it can cause inflammation, and we have an answer for that. The tenesmus was real. There is rectal inflammation, but it's all through adjacent pathology that's happening within the pelvis. So it's always nice to go back and try to explain all the findings. And now I'll remind myself, hey, don't forget about adjacent disease when you have pyuria, something adjacent to, but you shouldn't start there, guys, because if you start there, you're going to miss the most common cause of disease, which is actually within the cavity as opposed to outside the cavity. But Robbie, to you on like the AFP specifically, like if that does anything.
Yeah, Professor. So let me share a picture. So you're seeing a very small number of tumor markers have tremendous diagnostic value. Some of them have a little bit of diagnostic value, and as a Prof. Rez said, most of them have no diagnostic value, but can have some prognostic value. So what are the exceptions to the too many markers? It's in a patient who has lymphadenopathy and a really high LDH. It's in a patient who has suspicion for a neuroendocrine tumor who has a positive chromogranin A. It's in a patient who you suspect has oncogenic osteomalacia, as we've discussed, Prof. Rez, who has an elevated FGF23. And it's in patients who you suspect have a lymphocytosis and have positive flow that can diagnose the. And the markers here are very high in the right context. So if you have a prostate mass and a PSA over 20, you've diagnosed prostate cancer. If you have the Crab criteria and a very high paraprotein over 1,000, you've diagnosed multiple myeloma. If you have a large liver mass with the right features on CT with a positive AFP, you've diagnosed hepatocellular carcinoma. If you have the clinical context for a germ cell tumor, you've diagnosed choriocarcinoma in this instance. And so I think it goes back to what is your pretest probability of, and I think the pretest probability here, Prof. Rez, is possibly that the patient has a germ cell tumor. And I think you might have a very reasonable counter argument to say, well, his testicular ultrasound is negative. And I think that's where the fascinating feature of germ cell tumors, and germ cell tumors can originate anywhere in the midline of the body, be it in the pineal gland, in the mediastinum, or in the retroperitoneum. And so I think it's interesting. The features for germ cell tumors in this case, in my opinion, are the patient's gender and age. Germ cell tumors are unheard of in women, very rare, but they occur predominantly in men. His age is good for it. But I think the invasion into the bones is unusual. Cannonball Mets are also on the list for germ cell tumors as they are sarcoma. So I think you're seeing what Prof. Rez expected for us to play out is that the AFP should not cause the sun to set on sarcoma here at all. But I think for me, honestly, it gives me optimism for the patient, because I think a diagnosis of metastatic sarcoma is way more ominous and poor for the patient than a diagnosis of metastatic germ cell tumor. So if I'm really honestly closing my eyes and putting myself in the scenario that Maddie's in right now, is before the AFP came back, I was like, this is not going well at all for this patient. And when it comes back, it doesn't completely shed light off the most morbid hypothesis of sarcoma, but I think it gives hope and optimism to a potentially more gentle course for the patient. So that's my take. I'm curious what yours is, Prof. Rez.
I really love that. And honestly, with like GPT, and it would make you pause appropriately, but I think at the end of the day, it's really going to be just the tissue that will be the answer here. But I love what you said, Robbie, that it like gives optimism if this is a drug. Though I don't even know what like the prognosis, like this is all area that is foreign to me, and I would have to, read about and learn about.
All right, amazing discussion. So there's a little bit more after well, basically this is the last aliquot, but pathology from the lung lesion came back yesterday, and it was consistent with poorly differentiated carcinoma. But the pathology part said the morphology and the immunohistochemical profile is non-specific, and the tumor cannot be further classified based on the biopsy. So I'm curious what you make of that, what you think should happen next. Poorly differentiated carcinoma.
I think you need to talk to an oncologist. Like, I think, yeah, like there's no reason for any of us to, unless you don't have access to an oncologist and you have to learn this particular space. But what I would honestly do, and I'd be interested in what Robbie would do, is I would talk to the oncologist. Like I don't know that landscape well enough to understand like the uniqueness of pathology. And there are cancers of unknown primary site, but this really doesn't necessarily feel like that. And it's a poor sign if this is a cancer of unknown primary site based on the extent of the cancer involving the lungs, invading the bone, causing necrosis. So I think that I think it's not a good sign. I know it's not they don't say sarcoma, but I don't know how confident the pathologist is. So you have to speak to someone who lives in this space, and it just, I think, highlights a really important teaching about biopsy results. It's either they're positive, they're negative, or they just don't give you an answer. And in this case, it is a positive answer, but not a definitive as to etiology. So I don't know, Robbie, would you frame this as like cancer unknown primary site? Would you say this is, yeah?
I'm right there with you, Prof. Rez. This is at the beyond my comfort zone, and so I think this is a great opportunity to realize that your consultants are also teachers. And I think all too often we get really, really intimidated by them and kind of just say, "Hey, help me." But I think I would probably be calling them, and then I wouldn't be not now. I'm no longer shy about like asking questions to my satisfaction, which often is actually probably like 5 minutes too much for their own interest and bandwidth. But I no longer have any shame. So that would be the wisdom that I would try to impart on you: is remember that the subspecialists are also there to teach you, especially if you're in an academic center. So learn as much as you can from them. And I'm curious what you learned, Maddie. I know you probably weren't there since you rotated off the night, but what you saw in the documentation or.
Yeah, I've been following this case like multiple times a day because I was only there just admitting them, and so I wasn't there for the urology involvement and all that. But so yeah, I learned a lot from the reading through the oncology notes about the differential that they were thinking of, and you all were spot on about the features that were consistent with the different differentials. So just to, for example, so sarcoma initially was basically highest on the differential for the reason that you mentioned, the large mass, and also the bony erosion was very concerning for sarcoma. But then it was the germ cell tumor was then that kind of the highest concern, I think, based off of the elevated AFP. But then when the HCG was negative and then the scrotal ultrasound was negative, then that kind of went lower on the list. And then reading through the oncology note from yesterday, so when the biopsy came back as poorly differentiated carcinoma, this was framed as basically, like metastatic malignancy of unknown primary. And so they recommended an urgent EGD and colonoscopy to elucidate if this was a primary GI malignancy. So he is actually getting an EGD and colonoscopy today. I think he probably should be going in the next few hours. I thought I was going to have an answer to this case by by the time I presented, but he's getting a colonoscopy and an EGD today, and I think depending on that will I think guide the treatment. If it's a GI malignancy, I guess that will influence what chemo they do, but if not, they'll start treatment for just like poorly differentiated carcinoma. So unclear primary right now.
I mean, I think that if you just rewind the tape, the amount of learning that this case inherently has, I think, is through the roof. But the fact that the way you chose to tell the story just really, really allows the amplification of so many practical points, but also a lot of real life tension points as well. Yeah, I think how to approach a swollen leg, how to approach the rectum, how to approach that chest X-ray, how to analyze what cancer this might be is just pearls galore. So thank you for that. I'm curious if Prof. Rez have any reflections. I'd also be curious to hear yours and what you learned from this.
I want to hear Maddie's. I echo everything Robbie said.
Yeah, I think from this case makes me want to cry. It's like so sad. But in terms of like some of the takeaways, I think in retrospect, as we were going through it, kind of initially, kind of the rectal symptoms and the iron deficiency anemia, I think were downplayed, and I think I did not think about the value of those symptoms, I think, as much as I should have. But in retrospect, now that we're thinking this is very possibly like a GI malignancy, I think the iron deficiency anemia becomes quite relevant, and same with the rectal symptoms. But to be honest, it was really underplayed, both in my mind and I think also in the team's mind, because I think just the imaging was just so striking that the focus was like, oh, this has got to be some type of sarcoma or germ cell tumor. So the iron deficiency and rectal stuff was really downplayed. And what else? Oh yeah, Reza, to the point you made, like I think just the fact, proctitis, you think of infectious etiologies first, but thinking about how things external to the rectum and just compression can cause those symptoms. And also just the really sad reality, like when you have this kind of potential space in the pelvis, like how extensively something can grow and spread into the body before someone detects it. Like this guy had, he had 2 months of unintentional weight loss, but the symptoms that he picked up was like 2 days of leg swelling, and then was found to have this diffuse metastatic cancer, which is just so sad. So those are some of my takeaways, but I think, yeah, I think just like medically, I think like the differential for those cannonball lesions and the different aspects of this case that pointed to the different differentials, like erosion into the bone, sarcoma, the cannonball lesions, and the elevated AFP, germ cell tumor. And so it's been a really interesting case and just so sad.
Yeah, it's incredible to see you wear your emotions here, and I think the fact that I imagine you probably spent a couple hours with this patient at most, admitting them on a night shift and then passing on to the day team. But the fact that it weighs on you so heavily and so deeply is, I think, the kind of doctor I think we all want to be. It reminds me a lot, actually, of I think the most iconic RLR episode where Prof. Rez presented a case of ascites that turned out to be mesothelioma to me, and at the end of it, he couldn't hold back his tears. And it's an honor to know both of you and to share this space with both of you, not just because your ability to manipulate information and come up with clarity and conclusion is incredible, but that ability is only there because you care a lot. So yeah, I got some goosebumps here. Thank you. Zachary, with that, I'll pass the mic to you to take us home.
Gosh, where to start? What an incredible case, Maddie, and thank you for bringing it. I think I'm going to leave the teaching points on lower limb swelling, because honestly, I think we could talk on that for hours, and actually just start with proctitis. And Prof. Rez started to suspect that when the patient had the complaint of feeling the urge to defecate, but nothing coming out. And you can translate that into inflammation of the rectum. And the approach for colitis, we were taught, is the same as approach for proctitis, but with some differences. So you can think of them with the 4 I's: infection, inflammation, ischemia, and infiltration. But certain things change when you have proctitis. So when you think of infections, STIs become much more likely. When you think of inflammation, Crohn's colitis, at least 50% of the time actually spares the rectum. So most of the time when you have inflammation of the rectum, you should actually think more about ulcerative colitis. And then lastly, ischemia as a cause of proctitis is much more likely, especially in patients with chronic constipation, and they can get stir colitis. And then lastly, you also have to consider foreign bodies. We then had an incredible discussion on weight loss, where Rabih taught that while the simple framework is that it's just a caloric deficiency issue, either it being a hyperconsumptive state versus decreased intake, we can actually start to go a bit more into that. So when you talk about a hyperconsumptive state, that actually makes you think about systemic causes such as metastatic cancer that lead to that hyperconsumption. But whereas decreased intake on its own can cause weight loss with caloric deficiency. If you are thinking about a localized issue, localized cancer will not cause decreased weight loss unless it's in a very strategic place, such as in the abdomen, where you get issues with malabsorption and maldigestion. We then discussed the approach to cannibal lesions, which are round, large peripheral nodules. And the first thing to say is that while there are many specific things we think about, you should actually just go through the entire differential of what causes lung nodules, as otherwise you can miss things. But specifically, when you see cannibal lesions, you need to think of hematogenous mets from the cancers that metastasize hematogenously. And that includes renal cell, thyroid, choriocarcinoma, and sarcoma. Lastly, just a few quick pearls on cancer. So we often think of cancer as either compressing or invading and causing resultant symptoms, but sometimes it can be quite difficult. And for example, patients with a retroperitoneal lymphadenopathy, even radiologists can sometimes struggle to differentiate between a true mass from a malignancy versus just a reactive lymphadenopathy. But one way you can then focus down on that is that whenever you start to have true invasion, like in the bone, that's very unlikely to be something like just a lymph node and much more likely to be an actual cancer. We then discussed the decision to biopsy. And the first thing is always what's accessible and the safest. And once you've decided that, is to try and then decide what tissue can I get that will allow me to both get a diagnosis and stage at the same time. So for example, if you think that an abdominal cancer has metastasized to the lungs, try and get a lung sample because it'll allow you to stage at the same time as getting the diagnosis. Finally, we discussed tumor markers that are actually often overused. In some cases can be useful for recurrence of cancer, like with colon cancer, but most of the time are actually not useful unless you have a high pretest probability for a specific cause. So for example, somebody with a classic CT scan with a history of cirrhosis and a massively high AFP can clue you into the diagnosis of HCC. But oftentimes it can just be something that might be elevated and one cancer causing multiple elevated tumor markers that were not necessarily needed for the diagnosis. And I think finally, this case really just highlighted the importance of palliative care. I think something that I learned in medical school that I really think that we should all try to learn more about and educate ourselves on, because you will see it all the time in patients with these devastating diagnoses. And I think it can help our patients, but also ourselves deal with these sad cases. So thanks a lot and have a great day. Thanks further. Bye.
Perfection as always. I don't know how you do it every single time. So crisp, so clear, so easy to follow, so well enunciated and delineated. Big shout out to Eugene for keeping up with the complex case. Really appreciate you. And thank you everybody else. Really, really had a great time.